model focuses on using innovative approaches to assist the equip-supported countries to rapidly scale up the new WHO policies like Test and Start, meaning that we are no longer waiting for the CD4 counts of our HIV-infected patients to drop before we start them on treatment. But everybody who's HIV infected must be initiated on treatment, irrespective of the CD4 count. I work with a team of close to 250 people throughout the EQUIP consortium, and we are together making significant advances under the lead of USAID Washington, and we work side by side together with local USAID missions, the Ministries of Health in country, the local implementing partners who are currently funded by USAID for direct service delivery for HIV programs. EQUIP is a technical assistance model which focuses on 5 solutions which directly impact PEPFAR targets to expand treatment access. And the areas that we focus on are 1, the rapid test and start policy rollout support. The second one is differentiated models of ART service delivery, and we focus specifically on multi-month dispensing, either within facilities or at community level. The third one is strategies and technologies for a more efficient increase in HIV testing yield, initiating ART, retention on ART, and viral suppression, focusing on both children and adults. We also focus, number 4, on implementing treatment approaches that effectively respond to the needs of key populations.
Good morning, I'm Dr. Kevin Reilly. I'm an infectious diseases specialist living and working in Cape Town, South Africa. I work for the ANOVA Health Institute. ANOVA is a non-profit organisation that works to better the health of South Africans in partnership with our National Department of Health. Another role that I play is that I work as part of the EQUIP consortium. ANOVA Health Institute is one of the partners in the EQUIP Health Consortium. And EQUIP really is designed to try and bring skills and best practice examples to the Africa region. So ANOVA plays a number of roles within the EQUIP consortium, and I serve in a number of different functions within this EQUIP partnership. So one of the things that I do is I run the PrEP Technical Working Group for EQUIP, and this is a group of highly skilled experts trying to develop new materials and new methodologies and new ways of implementing PrEP in the Africa region, essentially looking for ways in which we may have impact on the HIV epidemic and help African countries to reach their 1990 targets. So the PrEP Technical Working Group is made up of a range of different experts that includes physicians, public health people, some statisticians, some health economists, and essentially what we try to do is to develop programs that could be implemented within each of the EQUIP countries. And this includes a range of activities. It may be activities such as advising on PrEP guidelines within countries. It might be doing things like assisting with modelling of costs that countries might incur should they plan to implement PrEP. Or it may be development of protocols that could be implemented and then assessed to see how well PrEP was implemented and how well it may function and what kind of impact it could have in countries. So that's the one role that essentially ANOVA plays, is by deploying people like myself and other experts onto technical working groups. But the other role is that ANOVA is an experienced implementer of programs. So ANOVA has taken the lead in key populations and in pre-exposure prophylaxis or PrEP, and actually is the implementer on the ground that would go and operationalize the plans of the PrEP consortium and some of the products that come out of the PrEP Technical Working Group. PrEP stands for pre-exposure prophylaxis against HIV, and it's an extremely exciting and effective new intervention that we're now able to add into the package of care that we have for preventing and treating HIV, that hopefully will really have a big impact on turning the tide of this epidemic. And in fact, I think it's one of the most exciting interventions we've had since triple therapy treatment for people who are already positive. So essentially the concept of PrEP is that you can take a single pill a day composed of 2 different antiretroviral medications, and taking that pill correctly provides an extremely high level of protection against being infected by HIV, even if one is exposed to a body fluid that contains the virus. In fact, the protection levels are probably in the region of above 90% and even approaching close to 100%, so a very powerful intervention. Now, PrEP is exciting for a number of reasons. Firstly, it is evidence-based and it's been shown to be extremely safe. The side effects that occur in PrEP are extremely minor, they're very easy to deal with, and generally they can be managed quite simply without having to stop or reconsider somebody who's taking a course of PrEP. So PrEP is safe, it's very effective. It utilizes medications that are already in wide supply because they are the same medications that are already stocked by pharmacists for people who are HIV positive needing treatment. So anybody today who is at significant risk of contracting HIV, and that has actually been defined by organizations such as the World Health Organization. These are people or populations where their risk of becoming positive is about 3% per year. So for every 100 people in a population like men who have sex with men, for example, if 3 or more of those 100 are expected to become positive per year, then PrEP would be an effective and cost-effective intervention to try to offer to that population group. So in this intervention, people need to be shown to be HIV negative because it is only for negative people to prevent infection. And if they've had a negative test or a series of negative tests and they're otherwise in good health and their kidneys are working well, then they are potentially eligible for this intervention. PrEP is an add-on intervention, so it's not a replacement for what people are already doing to prevent HIV. So for example, if somebody is using condoms consistently, nobody would recommend to them that they drop the condoms and substitute PrEP instead of. But what we would recommend is perhaps that if their condom use is not consistent, then adding PrEP to whatever condom use they're already achieving may be a very, very good gain in terms of the level of HIV prevention that they can achieve. So although I absolutely believe that PrEP is a fantastic intervention and it's been very useful in my own clinical practice, there remain a couple of challenges, and these are challenges that we're hoping the EQUIP consortium will start to answer. So one of the big problems that we have is that knowledge and demand for PrEP in the EQUIP countries is very, very low. This is simply because this is a new intervention. Nobody has done it before. There's very little knowledge among individuals in high-risk communities that they actually need PrEP or that they could benefit from PrEP. So that would be one problem. A second problem, and I guess also relating to accessibility, is that funding for PrEP has never really been secure. There's never been large amounts of funding dedicated to PrEP in the world before because the intervention didn't exist. And we now have an issue where many countries are struggling from a budgetary perspective to manage even the HIV positive disease burden that they have in country. And now there is almost an expectation that they implement this new PrEP development, and they may not have the budget to do that without impacting on the quality of their treatment services. So one of the things that EQUIP will be able to do would be to bring in resources, both technical expertise, on-the-ground staff in some cases, and new technologies and tools that will make it cheaper and more cost-effective for countries to implement the intervention. One of the key arenas that the EQUIP consortium has chosen to engage with is key population health services. Now, key populations are various population groups who have a particularly high risk of HIV acquisition and transmission. And there are various reasons why this occurs, but firstly, just to name them, the traditional key populations would be people who belong to groups such as men who have sex with men and other gay men, commercial sex workers, people who use and inject drugs. And essentially these populations, because of their behaviors, because of the environments in which they live, which are sometimes very stigmatizing, they have difficulty accessing health interventions, including HIV prevention and or treatment. And we find that rates of transmission are much higher in these key populations compared to their peers in countries. So for example, If we took a 30-year-old gay man and we looked at his lifetime risk of acquiring HIV without an intervention, it would be magnitudes higher than a 30-year-old heterosexual man with female partners only, living in the same kind of context. So the thing about key populations is that the context doesn't necessarily really shift their risk of HIV. A gay man is at high risk of HIV acquisition whether he's living in Cape Town, Johannesburg, Maputo or London, and he belongs in that key population, and the conglomeration of risks means that his rate of infection could be really high. There are other population groups where we know there's a lot of HIV seroconversion happening. And the prime group is probably adolescent girls and young women. So this group isn't officially a key population, but they certainly are a vulnerable population. They're not a key population because their HIV risk depends on their context. So for example, an educated woman living perhaps in central Johannesburg with a good job and private health care may not be at very high risk at all. She may be married in a monogamous relationship and her HIV risk is zero. But a younger woman living in a rural town or a mining village may be at much higher risk of HIV acquisition because of her socioeconomic and social context. So these groups that don't fit into the key population group are not being ignored. They're still termed vulnerable populations: adolescent girls, young women, migrant workers, prison populations, clients of sex workers, truckers. There are many of them where we can start to identify where HIV risk is significant and where further interventions could be of assistance. It's certainly pretty clear now from evidence that PrEP, when applied properly, correctly, to key populations, could have very large impacts on the HIV rates. So knowing that PrEP is a potentially very powerful and effective HIV prevention intervention, and that EQUIP has both access, funding, determination, knowledge and skill to implement programs in its partner countries, it would seem an obvious fit that EQUIP would want to promote PrEP within its partnering countries. And that really is what we're hoping to do now. So the two best evidence-based interventions to have an impact on a country's HIV response would be to prevent new infections, obviously, and PrEP can do that, and then also to provide immediate testing and treatment for those who may already be positive. And this has multiple benefits. Obviously, those people find out their status early and get correct treatment before they ever have symptoms or side effects of HIV and AIDS. But also, we know that if we decrease the amount of virus in HIV-positive people who are on treatment, they are far less likely to transmit that virus to their HIV-negative sex partners. So both PrEP and immediate test and treat are going to be priority focus areas of EQUIP. Now we believe in EQUIP that PrEP offers a multitude of benefits to any health division that is going to implement it. So not only do you prevent infections in individuals, which is extremely important, you're obviously preventing community infections, because there'll be many members within a community that is often PrEP that stay negative, don't become seropositive themselves, and therefore don't transmit the virus forward. There's also a whole lot of benefits for the health system. One of the things about PrEP is that it requires engagement in care. It requires people to be linked to a clinic, to be tested and shown to be HIV negative. And then once they're on PrEP, that HIV testing is recurrent. So one of the big benefits of a PrEP project to an HIV response is that your HIV testing rates go up. Your tested proportion of the population can increase. And not only do you test them once, because they're engaged in care, you do recurrent testing of these populations and individuals. That's really important for trying to know the epidemic and to track its course. So recurrent testing is a major benefit. While those individuals are at clinic level for repeat HIV testing and new PrEP medications, a couple of other things can also happen. We can take the opportunity to recurrently screen and treat STIs. So we'll be able to detect more of them and manage more of them in a PrEP program than we might without PrEP. And The other thing that you can do is risk reduction counselling. So since you talk to somebody every couple of months for their revised PrEP script and their HIV test, it's an opportunity to take a sexual history, see where the risks really lie, and to try and work with that individual to make plans to decrease their sexual risk behavior and obviously lessen their chances of HIV acquisition. It's also an opportunity to provide commodities such as information and educational materials, condoms, lubricant, family planning or contraception for women. So I think it actually strengthens a holistic response to the HIV response when you put PrEP into the package of care that you're offering. So although it's early days yet, there have been some real successes regarding PrEP. The evidence for PrEP was available as early as about 2010 to 2012. We were starting to see the initial studies come through. And often is the case with these kinds of new technologies is they remain very theoretical with very little practical implementation, and they don't get to people who actually need them, and that has not been the case with PrEP. So for example, in the developed world, in the US, there are tens of thousands of men who have sex with men who are already taking PrEP. PrEP is offered and paid for by some insurers, and the access points are becoming very defined, and men who want to use PrEP are able to access it. The next step, of course, is getting access for people in Africa. And this is where I think the successes are starting to come. So, for example, South Africa was the first country after the US to release PrEP use guidelines from its HIV Clinicians Society. South Africa was also one of the first countries to register PrEP with our Medicines Control Council for the use of tenofovir and emtricitabine, which are the two drugs in PrEP, for the purpose of HIV prevention. And since that time, other African countries have also registered the drug. So it is now registered in Kenya, it's recently been registered in Namibia, and certainly in the Namibia registration we would like to think that PrEP had a role in terms of providing the material and the pathway to regulatory approval from their Ministry of Health and relevant regulatory bodies. So I think we've seen some successes in countries realizing that this intervention might be suitable for some populations within their countries. We're seeing policies from these Ministries of Health starting to include information about PrEP and a need to start to at least develop pilot projects for PrEP and hopefully eventually scale them up into full-size and massive projects. We're seeing PrEP being included in antiretroviral use guidelines in various African countries supported by PrEP. So I think that would be another success. When it comes to on-the-ground provision of PrEP, certainly we've gained experience from a South African PrEP demonstration project for men who have sex with men. And other partners are providing PrEP to adolescent girls and young women, to sex workers, to people who use drugs. So we're starting to deliver the intervention on the ground, but also to learn the best ways of implementing this to get the maximum possible benefit that we can with the best possible efficiencies. So one example of EQIP's success in furthering PrEP within countries is what has been happening in Namibia. So EQIP has been working with the Namibian Ministry of Health and a local implementing partner called the Society for Family Health for very many months now. And we're almost there at the point where we'll be starting to deliver PrEP pills to people. In fact, that will happen on the 29th of June. And that really marks a real success for EQIP. It is the start of something big. I think this has been a learning pathway for everybody. We've developed a lot of skills and materials that can now be utilized by other countries to take them from this path where we have this very theoretical piece of knowledge that needs to be translated into programs that actually suit the countries in which they're going to run. And I think EQIP has really assisted in developing an effective roadmap that will be able to be leveraged by other countries as they move in their plans to making PrEP available. So I'm extremely proud to be part of the EQIP consortium. I think this represents a very important move forward for Africa, for the Africa region. because EQUIP is really the first time that a consortium of Africa-led partnerships or partners and African-led experts have come together to try and provide solutions for countries in our continent. And I think there's really something to be said for local knowledge and local networking, and I believe that EQUIP is going to be very effective in getting novel interventions into countries that have major impact in the quality of their HIV treatment services and of course now in their PrEP and other prevention services.
The critical thinking behind the focus areas is that in order to treat everybody who's HIV infected, health facilities are just not enough. And even if we do implement ways to fast-track patients within facilities, it will still not be sufficient. So facilities do need to be decongested, which means that countries need to move towards community-based HIV delivery models. And these could be community adherence groups or technology-assisted platforms for ART delivery, for example, the recently launched pharmacy ATMs. And we refer to these interventions as differentiated models of care. And in this particular examples, I have used a differentiated model of treatment distribution as an example. So once patients are no longer tested and treated at facility level, we want to make sure that the quality of care that they receive at community is not compromised purely because it's moved out of facility.
My name is Brooke Nichols, and I am a health economist, senior researcher here at HERO, the Health Economics and Epidemiology Research Office based in Johannesburg. I also work with Boston University, which is based in Boston, and together our organizations for EQUIP are specializing in the health economic technical assistance for EQUIP. So health economics in EQUIP works in two ways. One is that we provide assistance before we go in and implement any intervention, and we can estimate how much something will cost. So we can look at the health financing. Something part of our team has been involved in is to say how much will it cost to scale up this HIV-related program. And then on the other side, we also evaluate programs. So let's say we want to evaluate how PrEP is working in a certain country, pre-exposure prophylaxis. We can work with the team that's implementing the study and then tell them at the end, work with them to collect costs and patient outcomes and say, was this cost effective? Should you implement it, yes or no? And how much will it cost? There are two types of technical assistance that HERO and BU are involved in. One is that we help before an intervention is implemented, and we can tell you how much it costs. So, for example, there's a part of our health financing team will look at how much will it cost to implement test and treat in a country. And so we work with both EQUIP and also stakeholders within a country to help them come up with their long-term budgets for these programs. And secondly, we can also, so not only can we provide assistance before an intervention is implemented or before a specific policy decision is made and give estimates, but we can also go on the other end and work with a team and say, was this intervention that you implemented, was it cost effective? So should we be doing it, yes or no, and how much does it cost? So health economics is very important within the EQUIP consortium because it ties together all of the pieces. So we have lots of people involved in implementation and demonstration, and so we can tie together all these partners and actually say what we should be doing based on the results that EQUIP is getting. So if EQUIP is doing a demonstration project and they think it's working, we can come in and help essentially evaluate and cost it. So can a country afford it? Should they be doing it? And so we can help answer these questions as a health economics team. So far in EQUIP, I have been primarily involved in activities in Zambia, and one of the biggest projects that we're working on now is to help determine viral load scale up in Zambia. Because right now, the WHO recommends that there be viral load monitoring of patients on ART, and so what we do is we made a geospatial model which includes information on where facilities are located within the country, where labs are located, where the sample volume, so where patients on ART are by facility, and essentially it uses geospatial model to help optimize where new equipment should go. So if you're going to get a new viral load machine, where in the country should it go? And how are you going to get samples there? So also to route transportation around that. And then on top of all this, to cost it. So if you place a viral load machine in this province or in that province, how much of your population are you going to reach, and how much is everything going to cost in the end? So right now we're involved in many countries, so personally I'm working a lot in Zambia and Malawi, but we have members of our team and also the members of the technical working group that are involved in Haiti, and DRC, Zimbabwe, Uganda, and of course as well as Zambia and Malawi. For each country in a different way. So it depends on what the country needs are. So discussions with stakeholders, and usually there's some sort of a scoping visit that happens initially. And for example, the needs of Haiti can be very different than the needs of Zambia. And so it's really important in these scoping visits to determine what exactly we'll be doing. So in Haiti, one of our partners there has been involved in a lot of health financing, and also a lot of modeling that happens before something is implemented. Has been involved in a lot of that. And in Zambia, we're doing more of the evaluation of ongoing interventions. And so it really will depend on the country needs, because we can say what we think is important, but really what's important is what the ministry needs, what the local partners need, and the funders need. We've had a lot of success over the last year, actually before I joined EQIP, with our health financing team, with Teresa Guthrie. She was involved in a lot of helping countries determine their budgets for test and treat. So what are the budgets going to be to scale up your testing and your treatment program to reach the goals set by UNAIDS, the 90-90-90 goals. And so she was involved heavily in that, particularly in Zambia and Uganda. And that's sort of high-level budgeting. So it'll say how many resources are we going to need to implement this, and to help mobilize budgets around that. So that was one big success so far, and she's also been involved with Global Fund application in Zambia and securing funding by providing the budgeting for that. And most recently, work I've been involved in Zambia for viral load scale-up has been quite successful, because there's been interest from the stakeholders to use our model in order to determine where their next viral load machine should go, how should they route samples, and also costing for the viral load scale-up initiative. So we're still working on that, but we should have the final model ready and our final recommendations ready any day now. So overall, I think that the health economics in HERO, our technical working group, and our role within EQIP is very valuable, and it's great to see it integrated in a lot of countries moving forward. And it would be great within EQIP if we're continuing to be involved in all these countries, because it really brings another level into decision making when you are taking costs into account.
One example is multi-month dispensing, and as it stands, most of our patients in the African continent currently receive 1 month's supply of medication at a time, and that means they have to come to the clinic every month to collect medication, which is not necessarily the most convenient way to do it for them. A good example is a truck driver who lives, for instance, in Lesotho and drives trucks to Zambia. So he has to go through South Africa, and he would be away from home for periods of 3 to 6 months. If we could find a way of supplying the truck driver with 3 to 6 months worth of medication at a time, it would increase the likelihood of his adherence and reduce the fact that he would default. So implementing this kind of policy also then frees up healthcare workers to be able to take care of the sicker patients who are more in need of care, and allow stable patients to continue treatment on their own.
Hello, Ashraf's my name, Ashraf Grimwood. I'm the CEO of Ket and Pilo. or a PI, or Principal Investigator of EQUIP. I represent Ketempilo, which is a not-for-profit organization based in Cape Town, and we started about 14 years ago in Cape Town, and now we're working in all around South Africa and 4 countries in Africa. The focus of the work in some of the countries has really been looking at new areas of work, or breaking new boundaries. And the idea of breaking those boundaries is to reach the 390s. What can we do to support the local implementing partners to reach their UN goals? So in Zimbabwe, for instance, we are looking at new ways of testing for HIV, looking at different places within a facility. So what are the missed opportunities? So it's looking at testing in pediatric units, in STI or sexually transmitted infection units, in casualty, emergency, where men might be, where children might be, who might be infected without them knowing about it. And to support that, we've embarked upon a strategy to support self-testing. In Zimbabwe, there is a large study already happening for self-testing, but what we are going to be doing in Zimbabwe is looking at the partners of members of community adherence groups, patients who are already on treatment, who are getting their treatment, but we wanted to test their partners. And that we hope would then be able to help us reach more patients or more people who are not aware of their status. So that's a program that we're looking at launching in Zimbabwe. We're doing a similar one in Burundi, where we're going to be looking at the partners of sex workers and the partners of other key populations, especially men who have sex with men. And the idea is that sex workers will also be testing themselves plus the customers. The other group is in Nigeria, where we will be looking again at the partners of positive pregnant women, and maybe key pops and young women over the age of 18 to 24, because those are where we feel are the high-risk groups. So that's just the testing. Then we come into supporting the sites where there are large numbers of patients on treatment, and there we're looking at multi-month scripting or multi-month dispensing. So most places, and so that's going to happen all across the various countries. And the idea there is to look at, especially in Zimbabwe, comparing these community groups in Zimbabwe who are able to take home 3 months supply or 6 months supply of treatment, and compare those who get their treatment in the facility for 3 months. The idea is that if you're given multi-month drugs for 3 months or 6 months, is that we want to compare what your response will be. Will you be adherent? Will a 3 months be equivalent to 6 months in a community, and compare that to a facility? So it's looking at what are the various outcomes of various approaches. And if the 6 month is as successful as the 3 month for patients who are stable, that is, they're well and they're virally suppressed, that's probably where we'll go. There are challenges though, because how does a facility stock 6 months of supply of drugs? How does a person store 6 months supply of drugs in their own homes if they have problems with space, if they have space constraints? What about temperature? What about environmental factors that might impact on the efficacy of the drugs? I mean, these are debates which have come up in various countries, and these are real debates, and people need to think about how we manage these challenges. Certainly, to do the multi-month scripting and dispensing, you need to have patients who are virally suppressed. And unfortunately, most of Africa, viral load monitoring has not been one of the cornerstones of the HIV program. It has been an add-on research because of the cost. Now it's becoming more freely available, so now what we've got to do is going through a whole process of educating the healthcare workforce to make them realize that this is really one of the gold standards of management in regards to HIV, that we need to make sure that for a patient to, patients have to be virally suppressed before they can be classified as stable. Okay, they can be well, they can look well, but they might not be virally suppressed. And, and if they're not virally suppressed, obviously they need to have their adherence checked, they need to be counseled, they need to be checked to see if they're not resistant to the drugs that they're on at that present time. So the viral load scale-up is a really interesting challenge, because setting up the labs, or the labs are already set up in many places, how do we support the labs, how do we support the healthcare workers, how do we support the flow of blood to the facilities, and how do we support the flow of information from the facilities, from the lab to the facilities. And then the last component of that is, are the healthcare workers responding appropriately to the results that they're given? So are they reacting correctly? If the viral load is not suppressed, are they then managing the patient according to an algorithm or a treatment process that the government has deemed is appropriate for their community? So that's an ongoing exercise, and to scale up to the levels that are required to meet the numbers on treatment is obviously a very exciting challenge, and I think we are going to meet that challenge, because we've got the National Health Laboratory Services helping us, we've got lots of people involved with the mapping to see where the hotspots are. So all those things are coming together quite nicely now in places like Burundi and in Zimbabwe and in parts of the DRC. So the original starting of EQUIP was really looking at those various areas, meeting the needs of key POPs, viral load scale-up, multi-month dispensing. So really essentially to reach the 390. So everything we're doing is trying to get the people tested, to get the high yield, to get the facilities decongested of stable patients so we can add the new patients on therapy, and then making sure that those patients who are on therapy are suppressed, and making sure that they are virally suppressed, because we know if they're virally suppressed, the spread of the virus is dramatically reduced. So therefore, you're then able to slow down the epidemic as we reach the 390s, and then moving towards the 395s by 2030. So this is a stepping stone, hopefully in the right direction. So Yula and I spoke about what our purpose was when it comes to managing HIV. And we felt that we needed to get people onto therapy, so that was our action, to get people onto therapy. But once people got onto therapy, they really needed to take responsibility for themselves. And we were sitting together and brainstorming, and we spoke about choosing. So choosing life, choosing health came up. And we felt that choosing life and choosing health is a way of empowering your patients to then take responsibility for themselves. And that is why we drew the circle of life and almost an infinity sign, but that's the red ribbon of HIV. But it's about choosing life and choosing health. And the red ribbon is the start of HIV, because in the beginning, when HIV reared its ugly head in the early 80s, what was killing the people? The red ribbon of bureaucracy. And the idea was to cut the ribbon, so that that's why the red ribbon signifies in a way, being radical, being different, being challenging when it comes to the prevention of people getting access to therapy. And then moving beyond that, saying to people, you've got to take responsibility for your own life, for your own health. And that's why that's how the logo comes about. And that is why we find the work across Africa as part of a consortium really important, very critical, because we can't do this on our own, and we need to work together. We need to work together with the implementing partners, and we are grateful for the opportunity to really shift the boundaries when it comes to cutting the red tape and making people aware that they can do so much more for themselves. And obviously, we helping them to reach that does give one purpose and makes this work really fulfilling and rewarding. Success it depends on from which angle. I think one of the successes has been, in a sense, being able to get into a country and to create an opportunity for people to communicate, especially the partners, and to reflect on what they are doing. Unfortunately, that's not measured, but certainly I would imagine that to be a success, and that has been an opportunity in Zimbabwe, as well as in Burundi, in the DRC, and in Nigeria, all the countries we've worked in. There's been this amazing opportunity for people to get together, to debate, to reflect on what they've achieved, what they've not achieved, and how they can do better. And I do feel that we will reap the benefits of this in a year or so's time when we see that there's going to be a shift, a real positive shift, because what it's done with us being there, it's made people realize that, you know, that PEPFAR is serious, and that USAID is serious in making sure that these targets are reached. And how do we work together? How do we, we put away our egos and put away those petty differences so that we can achieve those goals? And I think that is very important, because this epidemic does have a major impact on the communities, especially the poorer communities, where they've got so many other challenges, and does impact on the macroeconomic situation in the country. So let's see what we can do. Let's see how we can work together. And I think we will see benefits. I can list quite a few things. For instance, like in Burundi, we helped the PNLS, or the Department of Health, in updating their guidelines, looking at introducing self-testing, to working towards those. In Zimbabwe, again, it was viral load support, especially in Chitungwiza, where we have been asked to help with setting up a laboratory in supporting the viral loads, scaling up for one of the IPs, and PSI is now doing that with our support, and that's been great. Setting up the community antiretroviral repeat groups, the CARGs, again in parts of Zimbabwe where none have existed before, so trying to get the community involved in strengthening community health systems when it comes to supporting patients on ARVs. Again, this is new, and that is innovative, so it's hopefully will help. So again, the ability, for instance, in Burundi, when it comes to self-testing, to work with key populations, both men who have sex with men and sex workers. So Ketempilo is a not-for-profit organization that started off by a bunch of really crazy HIV healthcare activists. Activists in the sense that we were really tired of people dying and we wanted to do something. And what we did in the beginning of our history, in 2003, we started rolling out treatment to people at the primary level of care. At that stage, treatment was only geared to the tertiary levels. So with the treatment the rolling out of treatment, we also then assisted the health systems in strengthening their approaches to managing HIV. So we did health system strengthening, we did treatment rollout. But soon we realized that for patients to be on treatment, they need to be adherent. So we rolled out the patient advocate model, supporting adherence very early on. 2004, we started doing the adherence groups. We developed contracts for patients, then had contracts with themselves. So we wrote contracts, people then got to, so we did all that stuff, and that's why we're still here today, because that work's still relevant. And then we also realized that our people were starving, and that if you starve, because antiretrovirals make you really hungry. So if you've got no food, you're not going to take your drugs. So we need to look at ways of feeding people. So we said, okay, patient advocates can now make sure that patients can get access to the childcare support grants, disability grants, foster care grants, pensions, etc., etc. So then we went into getting pensions and stuff all sorted out for patients. We then went into early childhood development, because again, in some of the households in KwaZulu-Natal, especially around Ilembe, Northern eThekwini and Ngundluvu, even the Eastern Cape and even in Amajuba, for instance, we realized that if we supported young caregivers in better managing and supporting their children did better. So we did early childhood development, and that then led on to, from early childhood development, let's do sexual and reproductive health rights in schools. So we're doing that now. So we're providing cadre of healthcare workers and social support workers in schools, and addressing things like sexual and reproductive health rights within schools, gender-based violence, access to no medical circumcision, access to family planning, testing, all that, which is now bearing fantastic fruit. And then linked to all of this is the training. So we train unemployed young people to become learner basic and post-basic pharmacist assistants, and those patient advocates then go through the career path. So we also made sure that the patient advocates we employ are able to be career paths. So they can become either a patient advocate, and once you become a patient advocate, maybe they can apply for a learner basic pharmacist assistant training, post-basic pharmacist training. Some of them have become social auxiliary workers, and the social auxiliary workers, our first bunch of people who graduated as social auxiliary workers, have then gone through and applied through UNISA and have become social workers. So you get that career path, you see. So from being unemployed to ending up as a social worker is a great achievement for somebody who wasn't able to afford college fees. And then we've done some other interesting programs, and one of the programs that we're really proud of is keeping negative mothers negative. So in parts of KwaZulu-Natal, where we're working with young pregnant mothers, we have done an intervention which has reduced significantly the incidence of HIV amongst these young women, negative women, making sure they come for testing regularly, making sure that their partners come for testing, making sure the households are tested as well, so that you get to the point that everybody feels responsible. What's your mode of access to getting to a hospital if a young mother is now reaching term? So all those kinds of stuff, and it just means it's conversation, it's education and training, and we've had some fantastic results. We still, and that's what we're presenting now at the AIDS conference. And then what else do we do? Oh, besides the adherence, we've got the DREAMS projects. We've got research here with PEPFAR looking at testing and treating everybody, and that's going on now for its third year. And then with the DREAMS project, as you know, is young women and girls. And then Global Fund, doing, again, adherence support, young women and girls in schools, making sure that we reduce the rate of HIV.
We have learned the importance of integrating and linking patient data to pharmacy data to lab data, and to use that information to improve patient management. We have formed partnerships with our laboratories, our pharmacists, our epidemiologists, our economists, and have created a national data warehouse that allows us to be able to monitor national program performance. This platform has also allowed the government to be able to monitor the HIV program at a country level, at a provincial level, district level, and also at a site level. And this means that we can send a manager at a clinic a report that says, these are the patients in your clinic that are not doing well and therefore need particular attention.
I'm Dr. Lee Berry, the Chief Operations Officer for the National Priority Programs of the National Health Laboratory Service, and together with Wits University, we are working on the EQUIP program under the Viral Load Scale-Up activity. So Wits University and the NHLS come with a wealth of experience and skills in implementing large-scale national laboratory programs. And we've been involved in scaling up CD4 testing for South Africa, HIV viral load testing. We've also implemented and scaled up the early infant diagnosis program, and in addition, TB diagnosis with the Gene Expert. So we have come with this wealth of experience to contribute towards the EQUIP program, specifically for viral load scale-up in a number of African countries. And currently we're working in 10 countries globally and working together with the Ministries of Health and various in-country stakeholders to improve their viral load scale-up programs. And certain activities that we've been involved with is, first of all, laboratory assessments. So we have designed a rapid laboratory assessment tool, and this is aimed at assessing every single laboratory in a country, specifically pertaining to HIV viral load testing, in terms of type of laboratory staff that is available, quality assurance within the lab, equipment that is used, and laboratory infrastructure. And this is working together with a GIS mapping team, so that is a Geoinformational Spatial Mapping team, and they are mapping every single health facility in the country in terms of its infrastructure, water requirements, power requirements, as well as road infrastructure. And together with that team and a health economics team that is doing costing, we are putting together a comprehensive and thorough model for the best placement of HIV viral load testing within Zambia. In addition, we have also been working on introducing some innovative technologies for strengthening the pre-analytical and the post-analytical sides of viral load testing. So we are working on improving specimen logistics, specimen collection and specimen receiving at the laboratories, as well as cold chain monitoring of those specimens. And then on the post-analytical side, we are working on trying to get the result back to the patient and the healthcare facility as quickly as possible. So we are busy developing a mobile app that is known as eLabs, and this is available on either a mobile phone or a tablet and can be used by the driver of the specimens as well as by the healthcare worker. And this will also be sending out alerts to the patient to go back to the facility to get their result, as well as alerts when there is an HIV viral load that is greater than 1,000 copies per mil. And we're working on a number of activities in Zimbabwe as well. So we've been working in one district, Chitungwiza, and actually setting up an HIV viral load lab from scratch and assisting this lab with technology selection, with documents for standard operating procedures, quality assurance, and verification of the analyzer. And we've assisted this laboratory with going live and scaling up access to viral load testing for the facilities that are in the near vicinity. So all of these activities are working towards strengthening the third 90 of UNAIDS 90-90-90 goals. And that goal being to increase the number of patients who are HIV positive being virally suppressed. The viral load scale-up activity fits in together with the entire EQUIP mandate, which is to improve and strengthen on the UNAIDS 390s. So the first 90 being number of people who are HIV positive to know their status and to have been tested. The second 90, those who are HIV positive to have begun antiretroviral treatment. And the third 90 for those who are on ARVs to be virally suppressed. So all these activities are being carried out by the different core partners within EQUIP, and NHLS VITS comes in with the third 90 to strengthen number of patients being virally suppressed. And I think we all work together as a really good team under EQUIP to try and reach those 390s.
My name is Dr. Ntombi Sigwebela. I'm a Deputy Chief of Party within the EQUIP program. I work under Right to Care. The EQUIP program itself is funded through USAID to provide technical assistance to PEPFAR supported countries as they scale up on HIV test and start. I am responsible for oversight of the technical activities in terms of delivering on the mandate or the objectives of the program. And one of the key areas that I focus on is ensuring that countries that we support are ready and have the capacity to implement test and start, meaning that they have the ability to find more people who are HIV infected, put them on treatment, and ensure that those who are on treatment remain on treatment. This is basically the targets that have been set according to UNAIDS 1990 strategy. What we do in terms of working with the different countries, after the initial visits and the agreement on which areas EQUIP is going to support on, which are based on the identified gaps in the country by the USAID missions, the Ministries of Health, and the partners that work within that country. We have developed a tool, which is a tool that assesses very rapidly the readiness in terms of available policies, staffing levels, the burden of disease, and the flow of patients within facilities, and the availability of drugs, the management of drug and laboratory supplies, the availability of laboratories for viral load testing, and the supply chain for delivery of commodities within facilities and outside of facilities. This tool we have used in a number of countries to identify where the bottlenecks are in terms of scaling up implementation, and it has proven to be very useful in that it assists countries to rapidly identify these bottlenecks, put interventions in place, and then be ready for the rollout. Test and start, or test all and treat all, as it is known in some countries, is important in terms of reducing new infections, as well as reducing mortality and morbidity from HIV infection. If we are to reach the UNAIDS 1990 goals, then it is important to focus on making sure that everyone who is diagnosed with HIV is put on treatment. The implementation capacity assessment tool that EQUIP has developed is very unique in that it is able to rapidly assess all the key areas that are important in the scale-up of test and start in order to reach the 1990 goals. Unlike other tools which might require a week to complete all the relevant sections or to evaluate the different program areas for HIV implementation. This tool can be used in a facility and information can be collected within 2 to 3 hours, and it gives you a snapshot of where things are and what it is that is causing challenges or might be a challenge going forward. The tool has been successfully used in a number of countries, which include Lesotho, Zambia, DRC, Malawi, and Burundi. What is unique again about the tool is that you can adapt it to the situation. The format that was used in Lesotho is not exactly the same as what was used in Zambia, because the health systems, the structure of the health systems is different in the different countries, but it almost accurately assesses the needs, the gaps, the human resources, the infrastructure, and everything that forms part of an HIV program. In Zambia, for example, the use of the tool was very important in helping the country to determine how they move treatment closer to the communities by decentralizing the distribution of drugs and also creating pickup points that will be closer to the community, and also working with multiple stakeholders to ensure that those who need to access treatment do so in an efficient manner. And it's also been used in Lesotho to identify key populations that were previously neglected, which were now readily identified, and there's going to be specific interventions that targets them.
I'm the Senior Technical Advisor for Maternal, Child and Adolescent Health Systems. This is a non-governmental organization that is part of the Vets Health Consortium and is under the School of Public Health at Vets University. So MATCH basically focuses on strengthening health systems by providing technical assistance to the Department of Health in South Africa, strengthening the policy development by providing evidence-based information to influence policy and practice in South Africa. They also provide technical assistance at provincial and district levels. At times at district levels they recruit their medical advisors and place them at district level to strengthen the district health management team. So MATCH was founded in early 1990s, and it was actually part of the reproductive health research unit. And there were then over the years, in late 90s, there was a restructuring, and it was registered as Maternal, Child, Adolescent Health Systems. Thereafter, then MATCH really focused on health systems only, although it is known as a research unit because it's got this very strong component. It conducts a lot of research, various research, clinical trials, health systems research, operations research, monitoring and evaluation as well. Match has been involved in many health surveys that have been conducted in South Africa. So, but with that and with its various funders, they've been able to assist in improving quality of care, in ensuring that the maternal registry is up to date for the South African Health Department. They've also been very much involved with strengthening prevention, HIV prevention, targeting adolescent and youth. So Match, with its various academic staff, it has a lot of academic staff, so it brings a lot of value in terms of informing the policy, mainly with child pediatric and youth health, as well as maternal health in South Africa. So part of our staff is Professor Kovedia, who is well known in South Africa in the HIV research and pediatric research. Match has been quite instrumental in KZN, supporting eThekwini Metro. As we know, the Metro has the highest population, about 3.7 up to 4 million right now, and it has a prevalence, highest of the prevalence rate, HIV in South Africa. So Match has been instrumental in providing technical assistance, strengthening overall health programs, but mainly through USAID PEPFAR HIV programs. Match also has been instrumental in supporting the re-engineering of the only children's hospital in KZN. So it's going to be one of the very big regional hospitals that is able to provide services for children within the country and also outside the country. So that's what Match brings, is technical capacity from academia, from policymakers, from researchers, from people who have been directly involved with health service delivery at both district, provincial, and even at national level. So it helps in that it then informs how Match contributes towards the EQUIP consortium, because it brings all these various levels of experience and knowledge. So Match, as it's well known by its short name Match, the Maternal Child Adolescent Health Systems, it is one of the 5 consortium members that is supporting EQUIP. So Match, as mentioned before, because of his vast experience and technical abilities in various sectors, in research, in pediatrics, strengthening adolescents' health, maternal health, as well as health systems, it brings really, truly rich experience and knowledge into the consortium. So Match has an experience in, as I've mentioned, quality of care. So it brings all the quality improvement models that have been implemented in Durban under the supervision of Match in country, and we are able to roll these models into other countries and share our lessons and make it more efficient for them, because they are taking the lessons that we've gone through, and it is quicker and it's richer for them, and they are able to avoid the pitfalls in which we had gone through. Match also brings a lot of technical assistance in terms of clinic laboratory interface, in that how is that done, to that we EQUIP focuses on like assisting countries to meet their UNAIDS 1990 goals by strengthening the universal access to HIV testing and treatment. So with that, one aspect that all countries have been looking behind is viral load testing. So MATCH, with its component in terms of clinic and laboratory interface, is able to bring advisors that are able to assess the capacity of labs and then be able to bring innovative solutions that are context, they take into consideration the context in which a laboratory is functioning, and be able to then implement something that will be sustainable, because then there is a lot of buy-in and they use already current practices that are practiced but maybe not efficiently, and they are able to bring in best practices and integrate with the routine practices in different countries. So in that way, MATCH is able then to really strengthen the whole aspect of viral load. So we're hoping in time in these different countries in which MATCH support, including Dominican Republic, in the Caribbean, Haiti, and then in Africa, in West Africa, is MATCH supports Ghana, and then in East Africa, MATCH supports Tanzania. One of the aspects, as well as I've mentioned, with the health systems and strengthening, MATCH is able then to develop what we call technical assistance plans that are site-based, through firstly conducting site assessment, being able to identify the best practices in each site, being able to identify the barriers in each site, and then bring in innovative solutions that could be implemented at site level for them to improve, because the main goal is to have as many people enrolled on treatment. So by MATCH providing all the tools, all the planning tools, all the service delivery tools, all the monitoring and evaluation tools that have been used and are currently used in Durban and in all the facilities in which MATCH supports. So we're able to bring those, adjust it and adapt it to a particular country, either in West Africa, in East Africa, in the Caribbean, and be able for site facility staff to be able to then use the adapted tools to strengthen their program. So there's a lot that each partner, consortium partner, contributes, but because MATCH finds its position in Durban, where there is high caseload, HIV caseload. So MATCH brings that experience of high volumes, big volumes of everything. So being able to expand, being able to think beyond small scale implementation. So in that way, we hope as MATCH we are positioning EQUIP in all these countries that I've mentioned in a better way, because although they may have a low prevalence and low caseload, they can be able to learn from us having managed big caseload and adjust our approaches that are evidence-based, that are guided by all these global policies and frameworks, and adjust them into their own context.
Then start. The concept actually started with UNAIDS, where UNAIDS felt that by countries strengthening and making sure that they put people on treatment, they are able to meet the 1990 goals, where people are able to be 90 people who need to be on treatment are firstly identified as HIV positive, then are enrolled into treatment, and to ensure that the 90 people in each country that are living with HIV have viral suppression. Then it means that we need to be able to ensure that they are tested for viral load and are adhering to treatment. And why is it so important in each country is because every year we see, mostly in South Africa, that even though we have the biggest HIV program, but every day we have high numbers of newly infected people. So by having people who are on treatment, consistently on treatment, are virally suppressed, our rate of new infection will go down, and eventually we will realize an AIDS-free generation in which everyone is working towards. So how then EQUIP supports Test and Start across the 4 countries that I've mentioned, it really depends on the status of each country, because what we realize is that each country then launches the Test and Start at different dates, and in the manner in which countries launch the Test and Start program varies. So some it's almost like a sudden nationwide initiative. In other countries, they want to select sites that can first implement, and then from that build up, they then add more sites to implement Test and Start. So, for example, in Haiti, where EQUIP is supporting Test and Start, which was launched in July last year, we started by conducting site-based assessment, where we're actually looking at what is the current status of those that are currently involved, what is the current caseload, what are the practices of testing, like what services are they being offered, where are these services being offered, and based on the caseload that currently the country has, the approaches being used is sufficient, are they implemented in a way that is efficient. So we look at all those things. What's the status of their laboratories, what's the status of their medication in terms of stock out and stock ordering, so we firstly look at that, because this is a preparatory period where we're looking at readiness. The country is ready to actually implement and to really scale up this program to ensure that there are more and more people enrolled into care. So that is our first approach. And we also, as part of that, in Haiti, we looked at costing, where we're saying, what will it take for a country then to be able to support this program, noting the scale in which it should be implemented? Do they have enough resources to be able to do so? So what is actually a cost per person to be able to put in treatment, and will the country be able to sustain that cost when there are more and more people added into treatment? So we look at these different exercises to be able then to assist the country and policymakers and their finance treasury department to be able to budget correctly and be able to ensure that there are no gaps in 2-3 years' time when the caseload has increased because of the program, and be able then to, in a way, be better at planning and for HIV program, for health programs going forward. So that was our first step that we implemented in Haiti, and then thereafter we identified where there were strengths and then where there were areas that needed support. And one of them was the monitoring and evaluation, where we identified that yes, people can be on treatment, but if their client data is not captured correctly, that impacts a lot of things. Firstly, it impacts the numbers where people are tracking the rate of enrollment. It also impacts the planning, where the resources are being planned to match the caseload. So we were able then, as EQUIP, to assist by bringing in monitoring and evaluation advisors to go to each site and be able to understand the current monitoring and evaluation system, and to bring in new standard operation procedures that could help in the way of managing their data, in the way that they calculate their data. We also were able to recruit medical advisors or clinical advisors to strengthen the clinical management, because without good clinical assessment, clients are not able to get quality of care, and they may actually not be clinical assessed properly, in particularly those clients that are struggling to adhere on treatment. So they need close assessment to ensure that the treatment is right for them to be able to adhere to the treatment, because this is a lifetime adherence, and in that way it helps with virus suppression. So we're able to help in that way in Haiti, taking those lessons and the site assessment, informing the practice, the costing exercises and cost modeling, informing the resource planning. And in that way, in fact, it has helped, because with costing in particular, looking at one of the programs that we costed was PrEP, because as much as the treatment is being scaled up, but we also are wanting to complement treatment with prevention activities. So in Haiti, we were required and we were requested to look at PrEP, how much it will cost and how many infections will be averted in using PrEP as one of the modalities. So we're able to provide that kind of information to the health department in Haiti, and in that way, in fact, it has informed their planning for a demonstration project. Now they are looking at just trying and piloting a PrEP in a small scale, targeting a key population in that. And all these initiatives in complements and the impact overall, goal of ensuring that people less people are infected, and those that are already infected are on treatment, virally impressed, and people that need not to be infected, then there is that prevention aspect of the treatment. So far, we're in the second year of the program, but we have noted some of the successes that we can, as EQUIP, be proud of in different countries. I'll start with Haiti. For example, in Haiti, through our technical assistance with just data, to improve data capturing, to improve data analysis, to improve data management, we were able then to provide accurate numbers in terms of like caseload, how many people are currently on ART. And with that, we then, the numbers then informed the country operational plan for 2017. In that, in Haiti, they were able, the USAID, Haiti, and PEPFAR program were able to demonstrate successes in terms of exceeding their yearly goal for 2016 in the number of people currently on ART. And with that, then they were incentivized in terms of their funding going forward. So this is one of our successes. One other thing in Haiti, as mentioned, is that we are working very closely with the Ministry of Health, and we have been instrumental in revising their HIV guidelines. And with that, we've been able to integrate the multi-month scripting and dispensing standard operation procedures, and together with the ministry, we've been rolling out the guidelines, and we are finding that they, like at site level, they are able now to implement the multi-month scripting and dispensing approaches. So we are happy with that. In Ghana, EQUIP has started with the site assessment as well, and with the site assessment, because in Ghana the USAID has never actually been a direct partner supporting implementing partners at site level. So EQUIP is the first partner to offer direct technical assistance at site level. So that is alone a success. And in Ghana, their program has been very much focused on prevention. So with EQUIP coming in country, there is that balance of prevention and treatment and care. So we are hoping to see more and more successes in Ghana, noting that EQUIP already has held a joint workshop with WHO to try and really roll out differentiated models of care. So we have high hopes that things will go very smoothly in Ghana and they will be able to accomplish their 90 country goals. In Tanzania, one of the successes I can highlight as an eastern country, we also went and they have very similar to South Africa in terms of their prevalence is quite high, and they have a high caseload of people living with HIV and on treatment. In Tanzania, they have good policies, good standard operation procedures, but sometimes translating that to practice is a challenge, similar to South Africa. And because EQUIP is African-based, South African-based, we have had experiences with that. We were able to share the micro-planning tools that have been used at different clinics in South Africa, and we were able to share those tools, and they were able to adapt it and be able to adjust, and in terms of the number of people that they are able as a site to test, the number of people that they're able to enroll as new client on treatment. So in that way, we've been quite successful to be able to share the tools and the tools being translated and adapted at a country level for them to be able to enroll more clients on care. So EQUIP is really powerful in that it's African-based, it's driven by African consortium partners that bring African solutions. We're hoping that we, through our pain in South Africa in terms of like the number of caseload of people living with HIV, the number of people currently on ART, will be able to share these lessons in other countries and inform their policies and their practices. And in that way, we also want, as EQUIP and as well as match by our technical assistant, our experiences and knowledge that we are bringing in different countries, sharing our tools, sharing our lessons and best practices, will be able to avert some of the new infections in different countries. So we are really hoping that EQUIP goes from strength to strength, partnering south to south with other countries, really being a Africanist tool to strengthen HIV programs across countries for the sake of ensuring that 1990 goals are met, and that we as Africans realize the AIDS-free generation.
Malawi has a population of over 17 million people, most of whom live in rural areas. 10.3% of the population in Malawi are living with HIV. Over 600,000 HIV-positive people are taking antiretroviral therapy. Viral load testing is an important part of the management of these patients. Routine or targeted viral load test results help by providing information on how well antiretroviral therapy, ART, treatment with HIV medicines, is controlling the virus. EQUIP is supporting and enhancing viral load testing in various countries, including Malawi. Malawi presents several challenges with regards to VL testing, and Partners in Hope, together with Wits Pathology, have developed and implemented relevant and effective interventions to overcome some of these challenges. Viral load registers were introduced to record and track patients' information and correct clinical management following their viral load test result. A standard operating procedure for viral load testing was developed and is expected to improve site-level viral load testing performance. The SOP includes the introduction of ART patient pre-screening by a designated clinic staff to identify those eligible for routine viral load test prior to consultation, based on the time a patient has been taking ART. This results in saving providers time and means less eligible patients miss their routine viral load test. A standard talk or information session was developed to inform patients about viral load testing and its importance in monitoring their ART effectiveness. The SOP recommends identifying a health facility focal person to take responsibility for viral load testing at that site. The process for viral load testing of an ART patient in the rural areas of Malawi looks like this. Before any ART patient can be identified as eligible for a viral load test, they must first access their ART clinic, often having to travel long distances, mostly on foot, to their nearest facility. Fatigue, weather, time and distance are major factors in their initial journey. The patient's adherence to ART is determined by conducting a pill count and interviewing the patient. The viral load sample is then drawn from the patient by finger prick. The sample blood spots are collected on the dry blood spot or DBS card. The sample requisition form and viral load register are filled in. The samples are dried for a minimum of 4 hours before they are sealed into an envelope and sent to the molecular testing laboratory for analysis. Sample collection generally occurs on a weekly basis, with DBS envelopes carried by motorbike courier to district and then on to molecular lab. Sample transportation may take a few hours. At the molecular laboratory, the viral load samples are entered into the laboratory database by a designated data clerk. The samples are tested using the Abbott machine. Results are entered into the laboratory database and printed for return to facilities. The average number of days from sample collection from patient and printing of results in the lab was 52 days, as reported in the National HIV Program Report 2016 second quarter. The paper-based results are then put into envelopes and sent back to the facilities utilizing the same couriers who bring the samples. Long turnaround times are a significant barrier to timely correct clinical management of the ART patients. At the facility, the results are entered into the viral load results registers and the ART Mastercards. In the event of a high viral load test result, the patient is actively contacted through phone call or home visit and requested to return to the clinic for the result to be given to them. In the effect of a high viral test, the patient is counseled on adherence and repeat testing done in 3 months' time. EQUIP is working to develop an electronic results reporting system to deliver viral load test results direct from Abbott platform to facilities. This is expected to significantly reduce turnaround times, resulting in more timely clinical intervention for those patients with raised viral load result. EQUIP is currently working with the Malawi Ministry of Health and partners to develop the early stages of a national clinical genotyping program, including training on results interpretation and appropriate algorithm to follow for the consideration of switch to third-line regime when available. The development of a third-line ART treatment program is currently in the pipeline. EQUIP supports ongoing supervision and mentoring where necessary to ensure correct collection of viral load to limit rejection rates. This is done in close collaboration with MOH Diagnostics Unit and lab supporting partners.
EQUIP is designed to be a rapid response mechanism which has been put together with the aim of implementing the right interventions in the right way, in the right place, right now. We are not here for the long haul. We are here to deliver immediate results.